Welcome back to Teaching Service Hospital Rounds. Today we are working through Clostridioides difficile infection, the most frequently reported hospital-acquired infection. We will follow one patient from his first loose stool all the way through a recurrence. Along the way, we will build the mechanism from the swallowed spore to the pseudomembrane, classify severity the way the guidelines do it, and choose the right drug at the right dose. This is a dose-heavy topic, so listen closely for the numbers. Let us start at the bedside. This lecture is built around the current guidelines, and every dose you hear is a dose you can write. Grab a pen if you like. We come back to the numbers at the end. Here is our patient. Mr. Reyes is a 74-year-old man on the general medicine service. He was admitted 8 days ago with community-acquired pneumonia, and he has been on ceftriaxone and azithromycin since arrival. Overnight, the nurse reports 6 large watery stools. He has crampy lower abdominal pain and a new fever. None of that is subtle, but hold on to the framing. New unexplained watery diarrhea in a hospitalized patient on antibiotics is C. difficile until you prove otherwise. That one sentence drives everything we do next. Keep 2 questions in your head as we go. Does this patient actually have the disease? And how sick is he? Those 2 questions organize the entire workup. Here's what you should take away from the first half of this video. First, define C. difficile infection and describe how the organism injures the colon. Second, trace the mechanism from spore ingestion through flora disruption, toxin release, and pseudomembrane formation. Third, name the antibiotic exposures and the host factors that raise risk. Fourth, recognize the full clinical spectrum, from silent colonization all the way to fulminant colitis. And fifth, spot toxic megacolon at the bedside and on imaging before it perforates. Work through them as we go, and see whether you can answer each one before I do. If you can do all 5 by the end, you will manage most of these patients confidently on your own. And here's the second half. Sixth, decide which patients should actually have a stool sent and which should not. Seventh, interpret the 3 stool assays: the glutamate dehydrogenase antigen, the toxin immunoassay, and stool polymerase chain reaction. Eighth, classify a patient as non-severe, severe, or fulminant using the real thresholds. Ninth, choose initial therapy by severity and know the doses cold. And 10th, treat recurrent disease and apply prevention and antibiotic stewardship. Notice how the second half is entirely decision-making: who to test, how to read the test, and which drug to write. Those decisions separate a good C. difficile plan from a reflexive one. Let us take the history. The diarrhea started on hospital day 7. He describes 6 large watery stools in 24 hours, with crampy pain across the lower abdomen that eases briefly after a bowel movement. There is no blood and no vomiting. He has not left the unit, and there are no sick contacts. He did have a low-grade fever last night. Notice what is present and what is absent. Watery, high frequency, lower abdominal, no vomiting. That pattern points at the colon, not at the small bowel or the stomach. One more thing to ask: has he had any laxatives or new tube feeds? Both produce loose stool, and both will confuse the stool assay if you send it. Ask before you send. Now the pertinent history. He has chronic obstructive pulmonary disease, hypertension, and stage 3 chronic kidney disease with a baseline creatinine of 1.1. Write that baseline down. It matters in a few slides. His medications include ceftriaxone and azithromycin, and a daily proton pump inhibitor. Overnight, the covering resident added loperamide for the diarrhea. 3 red flags are stacked here: a beta-lactam antibiotic, acid suppression, and an antimotility agent. The first 2 raise his risk. The third is actively dangerous. Build this habit. Always find the baseline creatinine before you call anything severe. A number that looks normal in one patient may be a large jump in another. On examination, he is uncomfortable but not toxic. Temperature is 38.3 degrees Celsius. Heart rate 104. Blood pressure 118/70. The abdomen is soft with diffuse, lower abdominal tenderness. There is no rebound and no guarding. Bowel sounds are present and active. This exam is reassuring in a very specific way. A soft abdomen with active bowel sounds argues against ileus and against perforation. Those are the findings that would push him into the fulminant category. So far, he is not there. One more habit: measure the abdominal girth and mark it. Serial exams are how you catch a colon that is quietly dilating. A single normal exam does not buy you the next 12 hours. Here are the first labs. His white blood cell count is 18,400. Up from a normal count on admission. Creatinine is 1.8, clearly above his baseline of 1.1. Lactate is 1.4, and normal. Albumin has drifted down to 3.0, A liquid stool specimen has been sent. Hold on to two of those numbers, the white count and the creatinine. Those are the exact two values that decide whether this is non-severe or severe disease. We will apply the thresholds shortly. Notice we did not send a stool culture, and we did not order an ova and parasite study. Neither adds anything after a week in the hospital. Hospital-acquired diarrhea has a very short differential. Let us define the disease precisely. Clostridioides difficile is a gram-positive, spore-forming, anaerobic bacillus. The spore form is what lets it survive on bed rails, on hands, and through alcohol-based hand rub. Here is the key concept. C. difficile does not invade tissue. It causes disease entirely through the toxins it secretes. That is why the presence of the organism is not the same as disease. Infection requires two things together, a compatible clinical syndrome and a positive stool assay. Miss that distinction and you will overtreat. One more naming point. The organism was reclassified from Clostridium to Clostridioides. Same organism, new genus. You will see both names in the literature. Now the epidemiology. C. difficile is the most frequently reported nosocomial infection, meaning healthcare associated. But the picture has shifted. Roughly 1/3 of new cases are community-acquired in patients with no antibiotic exposure at all. So the classic teaching that this is purely a hospital disease is out of date. Practically, that means an outpatient with new watery diarrhea and no antibiotic history can still have C. difficile. Keep it on your differential in clinic, not just on the wards. And do not let a young age talk you out of the diagnosis. Community-acquired cases occur in young healthy adults. Ask about antibiotics, then ask again about the last 3 months. Antibiotic exposure is the dominant risk factor, and two details matter. First, any antibiotic can do this. There is no safe class. Second, the risk window is long. A patient is at risk during therapy and for up to 10 weeks after the antibiotic stops. So when you take a history, ask about the last 2 to 3 months, not the last week. The classic high-risk agents are the beta-lactams, clindamycin, and the fluoroquinolones. And remember chemotherapy. It disrupts colonic flora the same way antibiotics do. One practical tip. When you review the chart, look at the discharge summary from the last admission. Antibiotics given at another hospital are the ones patients forget to mention. Some patients develop C. difficile with no recent antibiotics at all. 3 groups stand out: the elderly, the immunocompromised, and patients with inflammatory bowel disease. In inflammatory bowel disease, this gets tricky. A C. difficile infection can look exactly like a disease flare. So test before you escalate immunosuppression. 2 more contributors: acid suppression with proton pump inhibitors, and any recent healthcare exposure. Look at our patient. He is 74. He is on a proton pump inhibitor, and he is in the hospital. He checks several boxes at once, and that is typical. Most patients who develop this have 3 or 4 risk factors stacked together, not just one. Let us build the mechanism. It starts with the spore. Follow the panels from left to right. On the left, the spore is swallowed by the fecal oral route. Its tough outer coat resists stomach acid, and it resists alcohol-based hand sanitizer, which is why soap and water matter on a C. difficile unit. In the middle panel, the spore reaches the colon and germinates. Bile acids in a disrupted colon are the trigger. On the right, the vegetative rod multiplies and begins releasing toxin. The spore is how it travels. The rod is how it does damage. One more consequence of the spore: it survives on surfaces for months, which is why environmental cleaning with a sporicidal agent matters as much as hand hygiene. Now the step that makes a healthy person vulnerable. Look at the left panel. A healthy colon holds a dense and diverse bacterial community. That community consumes nutrients, occupies the mucosal niche, and converts primary bile acids into secondary bile acids. Together, that is called colonization resistance, and it keeps C. difficile from taking hold. Now look at the right panel. Antibiotics collapse that diversity. Primary bile acids accumulate, and primary bile acids are exactly what triggers spore germination. The niche opens, and C. difficile fills it. This is also why treatment is a balancing act. Every antibiotic you give to treat C. difficile also keeps the protective flora suppressed a little longer. Here's the injury step. Follow the 2 toxins down from the lumen. Toxin A and Toxin B both enter the colonocyte and glucosylate a family of regulatory proteins called Rho GTPases. Inactivating them collapses the actin cytoskeleton. Look at the middle cells. They have rounded up and their filaments are broken. 2 things follow immediately. The tight junctions pull open, which drives fluid and protein into the lumen, and neutrophils flood into the mucosa. Toxin B is the more potent of the 2, and it is the target of a monoclonal antibody we discuss later. A practical corollary: The toxin is what does the damage, so a test that finds toxin tells you more than a test that finds the gene. And here's the end result. Compare the two panels. On the left, the crypt epithelium is intact and the lumen is clean. On the right, the epithelium has been destroyed in patches, and yellow adherent plaques sit on top of the injured mucosa. Those plaques are the pseudomembranes. They are made of fibrin, mucin, dead neutrophils, and cellular debris. The word pseudomembrane matters. It is not a true membrane. It is an exudate, stuck to a damaged surface. When enough plaques coalesce, you have pseudomembranous colitis. And note this, pseudomembranes are not required for the diagnosis. Most patients never have them. Their absence excludes nothing. Their presence is simply confirmatory. Let us put the whole cascade together in one picture. Follow the top row. As spore is ingested, antibiotics or chemotherapy disrupt the colonic flora. Colonization resistance is lost, and the spore germinates into a multiplying rod. Now drop to the second row. The rod releases toxin A and toxin B. Those toxins inactivate Rho GTPases and collapse the cytoskeleton. Neutrophils pour in and the surface necroses. And finally, the pseudomembrane forms. Every treatment today interrupts this chain somewhere. Stopping the antibiotic protects step 2. Oral therapy attacks step 5. Fecal transplant works at step 3, by rebuilding what was lost. And Bezlotoxumab works at step 5, by neutralizing the toxin itself. Clinically, this is a spectrum, not a single disease. Follow the bar from left to right. At the far left is asymptomatic colonization. The organism is present, and the patient is well. Next is acute watery diarrhea, the most common presentation you will see. Then pseudomembranous colitis, the same symptoms plus visible pseudomembranes and a thickened bowel wall. And at the far right is fulminant colitis, with toxic megacolon or perforation. 2 teaching points. Patients can move rightward quickly, and only the shaded portion, from diarrhea onward, is ever treated. Colonization is the one place where doing nothing is right. Everything to its right needs treatment, and the regimen changes at the far end. Start at the left end of the spectrum. Asymptomatic colonization. In healthy adults, it is uncommon. Fewer than 3% carry the organism. But in hospitalized patients on antibiotics, that number jumps to about 20%. Read that second figure again. 1 in 5 inpatients on antibiotics is carrying C. difficile without disease. Now think about what happens if you send a stool on all of them. You will get positives, and you will treat patients who do not have the disease. This is why we are strict about who gets tested. It is also why a positive test never stands alone. Always ask, is this patient having diarrhea right now? If not, you have found a carrier, and carriers are not treated. The common presentation is acute watery diarrhea, more than 3 stools a day, occasionally bloody, often with mucus. Patients have lower abdominal pain and fever. And here's a finding worth memorizing. The white blood cell count is often strikingly high. An unexplained marked leukocytosis in a hospitalized patient should make you ask about stool frequency before anything else. Occasionally, the leukocytosis appears a day or 2 before the diarrhea does. Add pseudomembranes and bowel wall thickening, and you have pseudomembranous colitis. One more caution. Fever and abdominal pain are not universal. Older patients can present with confusion, a rising white count, and very little else. At the severe end sits fulminant colitis. It occurs in roughly 2 to 3% of cases, and it is the one you cannot miss. Look at the schematic. The transverse colon is markedly dilated. The haustral markings are lost, and the caliper marks the threshold, a colonic diameter of 6 centimeters or more on a plain film. Add colonic atony, meaning bowel movements cease, plus systemic toxicity, and that is toxic megacolon. Here is the trap. A patient whose diarrhea suddenly stops is not getting better. Perforation is the other feared complication. Mortality is high in this group, so the moment you suspect it, imaging and a surgical consult go in together, not one after the other. So who gets tested? The rule is short. Test only patients who are symptomatic, meaning active diarrhea or clear signs of colitis, and send liquid stool. If the specimen is formed, the laboratory should reject it, because a formed stool in a patient without diarrhea is colonization. There is one exception. If you are worried about ileus, where the patient has stopped stooling entirely, testing is still appropriate, because that patient may have severe disease with no output. Our patient has 6 liquid stools, so he qualifies. One more practical rule. Do not send a stool in the first day or 2 of laxative use. You will simply be testing the laxative. Wait for it to clear, then decide. Now the assays. There are 2 workhorse antigen tests, and they have opposite strengths. The stool toxin immunoassay detects toxin A and toxin B directly. It has high specificity, so a positive result strongly supports true infection, but its sensitivity is only moderate. The glutamate dehydrogenase antigen, usually called GDH, detects an enzyme produced by all C. difficile strains, toxigenic or not. It has high sensitivity, so a negative result reliably rules the organism out. Neither test alone is enough. Together they complement each other. Remember the pairing this way. The antigen test tells you the organism is present, and the toxin test tells you it is doing something. The third test is stool polymerase chain reaction, which detects the toxin gene rather than the toxin itself. Its sensitivity is the highest of the three, and that is exactly the problem. Polymerase chain reaction turns positive in a colonized patient who has no active infection, because the gene is present even when no toxin is being produced. So here is the rule. A positive polymerase chain reaction with a negative toxin immunoassay should not automatically be treated, unless the clinical picture genuinely fits. If it does not, you are probably treating a carrier. This is where hospital algorithms differ. Some laboratories report only the two-step result. Others report the polymerase chain reaction alone. Know which one your lab runs. Let us put the testing together. Start at the top. Only a symptomatic patient with new unexplained liquid stool enters this algorithm. Step 1 runs the glutamate dehydrogenase antigen and the toxin immunoassay together. Follow the three outcomes. If both are positive, this is C. difficile infection. Treat. If both are negative, look for another cause. If they disagree, and that is the common trap, move to step 2. Stool polymerase chain reaction becomes the arbiter, but read it beside the bedside. A positive test with no colitis picture means colonization, and colonization is not treated. Learn this shape. It prevents most of the overtreatment we see. And when in doubt, go back to the patient, not to the printout. Severity classification drives therapy, so learn the thresholds exactly. Non-severe disease means a white blood cell count under 15,000 and a creatinine under 1.5. Severe disease means more than 10 bowel movements a day, a white count above 15,000, or a creatinine above 1.5. Fulminant disease is different. It is defined clinically, not by a laboratory value. Hypotension or shock, the need for intensive care, ileus, or megacolon. Any one of those makes it fulminant, regardless of the white count. One more point about the creatinine. The cutoff here is an absolute value, not a change from the patient's own baseline. Know which definition your institution uses. Now apply it to Mr. Reyes. His white blood cell count is 18,400, which is above 15,000. His creatinine is 1.8, which is above 1.5. He meets the severe criteria on both counts. Now check the fulminant criteria. His blood pressure is stable. He does not need intensive care. His abdomen is soft with active bowel sounds, so no ileus, and there is no megacolon. So this is severe, not fulminant. That distinction is not academic. It changes the drug, the dose, and the route. And notice what did not matter. His fever, his heart rate, and his lactate are not part of the classification. Useful clinically, but not part of the definition. When do you image? Obtain a computed tomography scan of the abdomen and pelvis if you suspect a complication, toxic megacolon, perforation, or a patient who is deteriorating. You are looking for colonic wall thickening, pericolonic stranding, or free air. A plain abdominal film is quick and useful when you simply need to measure colonic caliber. Endoscopy is not routine. Consider a flexible sigmoidoscopy when the diagnosis remains uncertain, or when the patient is not improving on standard therapy. Pseudomembranes, seen directly, confirm it. Endoscopy carries a real perforation risk in a severely inflamed colon, so do not order it casually in a sick patient. A limited flexible sigmoidoscopy is enough. Before you write for any C. difficile drug, do 3 things. First, discontinue the offending antibiotic as soon as it is safe to do so. That single act is often the most powerful intervention you have. Second, stop antimotility agents. Remember the loperamide our patient received overnight. Slowing the colon keeps toxin in contact with the mucosa and can precipitate megacolon. Stop it. Third, stop cholestyramine if the patient is on it, because it binds vancomycin and will neutralize your therapy. Then place the patient in contact precautions. And do not delay the first dose while you wait for confirmatory testing in a sick patient. If the picture is convincing, start empirically. Now the drug choice. The guidelines have shifted. Fidaxomicin is now preferred over vancomycin, regardless of severity. Why? Fidaxomicin is a narrow-spectrum macrocyclic antibiotic. It kills C. difficile while sparing much of the surrounding colonic flora. Because the protective flora recovers faster, the recurrence rate is meaningfully lower. Initial cure rates are comparable. The catch is cost. Fidaxomicin is expensive, and many formularies restrict it, so oral vancomycin remains a completely acceptable alternative. Metronidazole is no longer first line. One practical exception: intravenous vancomycin has no role here at all. It does not reach the colonic lumen. Oral or rectal only. Here are the regimens, and I want you to learn these numbers exactly. For non-severe or severe disease, the treatment is the same. Fidaxomicin 200 mg by mouth twice daily for 10 days, or vancomycin 125 mg by mouth 4 times daily for 10 days. For fulminant disease, the regimen changes completely. Vancomycin 500 mg by mouth 4 times daily, plus metronidazole 500 mg intravenously every 8 hours. Notice the vancomycin dose quadruples, and fidaxomicin does not appear in that row. One safety note: oral vancomycin is minimally absorbed, so you do not check levels and you do not adjust for renal function. Let us unpack the fulminant regimen. High-dose oral vancomycin is the backbone. 500 mg 4 times daily. It is not absorbed, which is exactly what you want. It acts in the lumen. Intravenous metronidazole is added because when there is an ileus, oral drug may never reach the distal colon, and metronidazole given intravenously is excreted into an inflamed colon. For the same reason, consider vancomycin per rectum as a retention enema. Fecal microbiota transplant can also be considered. Do not substitute fidaxomicin here. Watch this patient closely. Blood pressure, urine output, abdominal exam, and lactate. Deterioration here is measured in hours, not days. Now the part that saves lives: knowing when to escalate. If a patient worsens, get an abdominal computed tomography scan and call surgery urgently. The triggers are new ileus, a rising white blood cell count, a rising lactate, shock, toxic megacolon, and peritonitis. Do not wait for all of them. Anyone should prompt the call. The surgical options are subtotal colectomy, diverting loop ileostomy with colonic lavage, or colonic lavage alone. Delayed surgery in fulminant disease carries very high mortality, so involve the surgeon early, and involve the intensive care team at the same time. These patients need volume, vasopressors, and close monitoring while the operative decision is being made. 2 loose ends. First, if the patient still needs antibiotics for another infection, continue the C. difficile therapy for at least 7 days after that other antibiotic stops. Do not end them on the same day. The colon needs a protected window to recover. Second, do not repeat stool testing to confirm cure. Stool carriage persists for 3 to 6 weeks after treatment ends, so a positive test at that point tells you nothing. Retesting as a test of cure is explicitly not recommended. Judge the response clinically instead. One more practical point: do not repeat the test to decide about isolation either. Isolation decisions follow symptoms, not stool assays. Follow your hospital policy. Now recurrence. And this is where C. difficile earns its reputation. Between 15 and 30% of patients recur after the antibiotic is stopped, and most recurrences happen within 2 weeks of stopping therapy. Why? The spores were never eliminated. Antibiotics kill the vegetative rod, but not the spore. And until the normal flora rebuilds, those spores can germinate all over again. Recurrence risk climbs with each additional episode, so counsel the patient before discharge. Returning watery diarrhea means calling, not waiting. And there is a second mechanism: a genuinely new infection from a fresh exposure. Clinically, you cannot tell them apart, and the treatment is the same either way. 3 weeks after finishing therapy, Mr. Reyes calls the clinic with watery stools again. This is a first recurrence. 2 options: fidaxomicin 200 mg by mouth twice daily for 10 days, or vancomycin 125 mg by mouth every 6 hours for 10 to 14 days. Notice the vancomycin course is longer here than in a first episode, 10 to 14 days rather than 10. A practical point: many clinicians switch agents for the recurrence. Vancomycin first, then fidaxomicin, or the reverse. One more thing to check at this visit: did anything else change? A new antibiotic course, or a new proton pump inhibitor, is often the trigger. Find it and remove it. There is one more tool for a first recurrence: Bezlotoxumab. It is a monoclonal antibody that binds toxin B and neutralizes it. Notice that it is not an antibiotic. It does not kill the organism. It is given as a single intravenous dose, often milligrams per kilogram during the antibiotic course, not instead of it. Adding it lowers the rate of the next recurrence. One important safety point: use caution in patients with congestive heart failure. More heart failure exacerbations were seen in treated patients, so weigh it carefully. Access is the practical limit here. It is an infusion. It is expensive, and it usually needs approval. So identify candidates early, rather than at the last minute. For a second or later recurrence, the approach changes again. Use Fidaxomicin, or a vancomycin pulse and taper, where the dose is stretched out over weeks so the flora can rebuild between doses. Consult infectious diseases at this point. These patients need a plan, not another reflexive 10-day course. And here is the threshold to remember. Fecal microbiota transplant is recommended after a third episode of C. difficile. Transplant restores the missing microbial community directly, which is exactly what antibiotics cannot do. Transplant is delivered by colonoscopy, by enema, or in capsule form, and careful screening of the donor material is what makes it safe. Refer rather than improvise. Finally, prevention. For a patient with a history of severe or recurrent C. difficile who now needs antibiotics for something else, oral vancomycin, 125 mg once daily during that antibiotic course, lowers the risk of recurrence. Weigh the risks and benefits individually. This is not for everyone. Beyond that, the fundamentals do the heavy lifting. Avoid unnecessary antibiotics. Narrow the spectrum as soon as cultures allow, and stop acid suppression when there is no clear indication. And on the unit, contact precautions and hand washing with soap and water. Alcohol-based gel does not kill spores. Environmental cleaning with a sporicidal agent closes the loop. Here are the mistakes I see most often. First, testing formed stool. You will find carriers and treat them. Second, treating a positive polymerase chain reaction in a patient with no colitis picture. Same error. Third, leaving an antimotility agent on the medication list, which traps toxin against the mucosa. Fourth, and this is the dangerous one, celebrating when the diarrhea stops in a sick patient. In fulminant disease, that means atony, not recovery. Fifth, sending a test of cure. And sixth, classifying severity without checking the baseline creatinine. Every one of those is avoidable at the bedside, and every one of them shows up on rounds. Catch them in your own plans first. Let us close the loop. Assessment. A 74-year-old man on hospital day 8 with severe C. difficile infection following ceftriaxone. He meets severe criteria on both the white count and the creatinine, and he has no fulminant features. Plan. Fidaxomicin 200 mg by mouth twice daily for 10 days. Stop the ceftriaxone. His pneumonia course is complete. Stop the loperamide immediately. Hold the proton pump inhibitor. Contact precautions. And follow the response clinically. No test of cure. And counsel him before discharge. Returning watery diarrhea in the next 2 weeks means calling the clinic, not waiting it out. That conversation catches most recurrences early. Let us recap the essentials. C. Difficile is toxin-mediated disease spread by spores, and antibiotics are what open the door. Test only symptomatic patients, and only liquid stool. Interpret a positive polymerase chain reaction beside the bedside picture. Never alone. Classify severity using the white count, the creatinine, and the clinical state. Fidaxomicin is preferred at every severity except fulminant, where you use high-dose oral vancomycin plus intravenous metronidazole and call surgery early. And after a third episode, think fecal microbiota transplant. And one last habit. Before you treat, ask whether this patient truly has diarrhea today. That question alone prevents most of the overtreatment. These are the primary sources behind this lecture. The current Infectious Diseases Society of America and Society for Healthcare Epidemiology of America guidance, the American College of Gastroenterology clinical guideline, and the major trials behind Bezlotoxumab and fecal microbiota transplant. If you want to go deeper on any point today, start with the guideline documents. They are readable and they contain the severity definitions we used. Thanks for rounding with me. Go back to the bedside, ask about stool frequency, and check the creatinine. One more suggestion. Read the severity table in the guideline yourself. Seeing the thresholds in the original document is what makes them stick.